in listen-only mode.
Wonderful. Well, hello everyone, and welcome to our webinar series, Weathering Change, Local Solutions for Stronger Communities. You can advance to the next slide. Our webinar series is brought to you by the Center for Climate Preparedness and Community Resilience based at Antioch University's Climate Resilience Toolkit. I'm Krista Daniels, and I serve as a senior faculty for Antioch University within the Environmental Studies Department. As you can see on the screen, our center's mission is to strengthen communities to prepare, respond, and recover in the face of climate impacts and other disruptions through collaborative, innovative solutions. If you would like more information about our center or any of our programming, you can always visit the URL that is listed on this slide. Next slide, please. I would like to touch upon quickly the capacity and programming we do here at the center. This webinar series, now in its 7th year, is a critical piece of delivering our mission and vision. However, we also have capacity building opportunities for our audience in attendance right now. We offer things like online courses on climate resilience that can be taken for credit or as professional development. Each course runs 4 weeks and is fully online and asynchronous. You can take only one course or more, or even take a set of courses that would enable you to obtain a climate resilience certificate from Antioch University. You can visit the link on this page to learn more about those courses and our certificate program. Next slide, please. The next course in the series is starting actually January 26th. It's taught by myself and is called Climate Impacts Public Health. Again, it is a 4-week online course, and registration is available at the link listed on the slide here. So if you're interested, take a look. Next slide, please. Something else I wanted to alert you about is that our upcoming conference is coming up this year. It's going to be held in Portland, Maine on May 11th and 12th. It's at the Holiday Inn by the Bay. This is another critical capacity building component of our work. It is a convening that occurs on the off years of the National Adaptation Forum. This is going to be our 4th convening, and we are lucky to be partnering again with NOAA, but also with the Island Institute and the City of Portland. We hope many of you can join us that day for the 2-day convening that will be focused on implementing action at the local level. Next slide, please. I also want to just mention that we also have sponsors before I introduce Ned. We have 2 webinar series sponsors, Town Creek Foundation and the High Meadows Fund. Both foundations have made significant positive impacts through their programming and dedication to creatable, sustainable communities. So I just wanted to mention that. I now have the privilege to introduce you to Ned Gardner. He's the engagement manager for the U.S. Climate Resilience Toolkit team. Ned's going to be moderating today's broadcast, and I'm happy to turn the mic over to you, Ned, and to welcome you and thank you for your involvement and expertise.
Thanks very much, Krista. Good morning, everybody. Climate Resilience Toolkit was set up as a resource to help people access all of the federal data tools that and reports and so forth that deal with climate information, so that communities, local governments at state and local levels, and communities and businesses could access federal resources through one common portal. It's at toolkit.climate.gov, and several resources that are foundational to us are going to be featured today. So I'll take a moment to briefly review those. An underlying resource, since we represent efforts by more than a dozen federal agencies that are united through the U.S. Global Change Research Program, that program develops the National Climate Assessment, the most recent of which has produced a chapter on the Northeast with emphasis on 5 different important impacts in the Northeastern United States, which you see depicted on the left side of the screen. Human health is going to be the topic today, and you can see here depicted the population centers throughout the Northeastern United States. In the realm of human health, we have some very important collaborators in the toolkit team. You can find the Northeast section of the toolkit by going to the Regions button at the top of the page, where you can find case studies, tools, reports, training courses, and a page devoted to our federal partnerships throughout the region. There's also a health section of the toolkit, within which there's a focus on health through this NIHIS website that is linked within the toolkit. NIHIS includes our resources focused on heat include case studies, several of which are listed here in the upper right panel that you're seeing, and a number of tools, 11 different tools that directly deal with climate, health, and heat. So we hope you'll take a moment to take a look at our website to get some more insights after today about the ways that climate influences health, particularly related to heat. One of the main frameworks for heat health comes from the Centers for Disease Control and the Building Resilience Against Climate Effects framework. There is a preview web page within the Climate Resilience Toolkit on BRACE, which you can find by going through our tools section or through the topics, the health topic, or through the Northeast region. And what you'll see on that site is a preview of BRACE, as well as this graphic depicting the steps to resilience. I want to take a moment and point out that the steps to resilience is a framework that spans all of the different topic areas, 10 different topic areas within the Climate Resilience Toolkit, and represents a common set of steps that any person going through climate resilience planning and decision making would undertake. We've labeled them: explore hazards, assess vulnerability and risk, investigate options, prioritize and plan, and take action. But these are really consistent with the 5 steps in the BRACE framework. There's a slight difference in the numbering and where they include certain steps, but essentially the steps to resilience is a common framework across all subject domains. And so we encourage communities to use this framework so that they can work across disciplines using common language and work with consultants, whether in health or transportation or any other domain of expertise. Another concept that's going to come up in today's webinar deals with vulnerability. So I wanted to take just a moment to describe what we mean by vulnerability when it comes to climate adaptation planning. You'll hear the term today, exposure, which deals with the degree to which a population or individual is subject to the influence of a climate-related hazard, and for instance, a tick-borne disease. If that person is particularly sensitive, they'll have a different potential impact from that exposure than if that person is not sensitive. So we distinguish these various factors when assessing vulnerability and contrast them with the adaptive capacity that that person may have. For instance, access to emergency room, doctor, transportation, air conditioning, what have you. And when you combine all these factors together, you come up with an understanding of what vulnerability is. So this definition and this framework, they're all integral to the way that resources within the Climate Resilience Toolkit can be used by people across any domain. And with that, we're going to shift focus now to our featured speakers. I want to take a moment and point out that if you do have a question, please use the questions panel in the software on the right side of your screen. A number of people have already found that questions panel. Please write your questions to all panelists, and to the extent we're able to, we'll get your question answered during today's webinar or by recording and posting those answers online after today's session. This presentation will be recorded and will be on the communityresilienccenter.org website. So If you have a colleague who was not able to make it today, please let them know. We will indeed post this recording. And of course, if you're having technical problems, use the chat window and send a message to the host, and either Terry or I will get back to you with some instructions. At this point, we're going to turn the microphone over in just a moment to Matt Cahillane, who is a public health program manager with a background in adult education and environmental health. His current projects include building community resilience against climate change and helping town health officers to solve environmental problems in housing, pest control, and sanitation. He administers a CDC grant on climate change under the BRACE program that I just described a few moments ago. His educational background includes training as a wilderness EMT. He has a Bachelor of Science in Preventive Health Studies from UMass Amherst and a Master's of Public Health with a focus in behavioral science and health education from UCLA. As of November of last year, his health intervention projects included measuring community resilience, emergency preparedness for severe weather, and teaching tick-safe practices. With that, I'll turn it over to you, Matt, and we'll go to the first slide in your presentation.
Great. Hi, this is Matt, and I wanted to thank Professor Daniels and Antioch University for inviting me to share my perspectives on climate and health issues. Let's start off this with a few basic terms used in the climate and health field. You can advance on to the next slide. So in the field, we want to talk about some of these terms that you may come across. Some of them mentioned already. Adaptation and mitigation, two ways of managing climate impacts. People can adapt to changing conditions or work to mitigate the drivers, greenhouse gases mainly, or they can do both. In terms of exposure pathways, we're talking about a linear path from hazards to their effects on people. So to try and find the right information, you need to look at the path from environmental hazards to actual exposures to health outcomes, and Dr. Bush will talk more about this topic. In terms of epidemiology and health statistics, this is the study of the patterns of disease. To understand the health outcomes, you need to look at the science of health determinants, biostatistics, the natural history of disease, plus understand the correct study methods. The next is direct and indirect impacts, and sometimes these are confused. Some impacts are direct, such as rising temperatures and heat stress. Others are indirect, such as disasters and mental health outcomes. One is a kind of a one-to-one ratio, which is well understood. The other has many different pathways of exposure and impact. The next is assessment and intervention. And I think it's important for people to know an assessment generally explores the basic conditions that exist now. So they don't necessarily look at associations that are trying to describe what is. Sometimes they do. An intervention attempts to change conditions and health outcomes. It's a really activated, involved process with either individuals or a community group. And finally, resilience. Simply put, it's the ability to bounce back. Yet it's defined differently for various issues, such as physical infrastructure, individual people, and communities. So I think during the next year, DHHS Antioch will be studying the concept of health resilience at the community level, and I'm sure over your coming career, you'll be acting upon it and learning more about how to put it into place. Next slide. So let's talk a little bit about exposures, and this could be one viewed as a part of the exposure pathway. This image is just one way to look at direct and indirect health impacts of climate change. And to understand this graph, you can kind of begin in the middle. You see four hazards of rising temperatures, extreme weather, rising sea levels, and increased CO2 levels. And then you move to the outer ring to see the types of exposures that these hazards might cause, anything from direct impacts of extreme heat or air pollution to more indirect ones in terms of infectious disease and, as we mentioned before, mental health. And if you click on the slide now, it'll open it up and you'll be able to see the other actual health impacts that come out of it. Obviously, these health impacts often have multiple drivers. So one of the complex jobs in public health is trying to tease out some of the biases and try and learn more about association or causation. It's not easy. Although you'll hear many health and environmental professionals link the three events in simple and direct ways, you should be cautious of the easy answers here. So we've moved, one of the reasons is not only we've moved on to age distributed media, but there's also lots of disinformation out there and very easy to spread. So we're cautious about that. Next slide. We're going to talk about 3 levels of kind of response to this. We're going to talk about, you can imagine a response to climate and health issues being at 3 different levels, the national, state, and local levels. And we'll have some examples here from New Hampshire. Here are some examples of response efforts at the national level. First one you can think about is leadership. Clearly, I work directly with CDC on climate and health issues, but EPA, NOAA, and others are also working on the issue of environment and health. Assessments, we do also. Coordinate and publish systemic reviews at the national level, like the National Climate Assessment that was mentioned earlier by Ned, and they fund research on changing conditions and risks. Then you move on to kind of that intervention piece, right? CDC Climate Ready States and Cities basically has funded 18 states and cities plus 7 tribal nations and academic partners that work on these interventions. And NOAA is also working on it too with their coastal resilience grants and EPA's climate change research grants. Then finally, policy initiatives on both mitigation and adaptation. A good example of that would be the Clean Power Plan, which for a while was initiated in order to try to reduce the impact of emissions with a specific focus on human health. Next slide. So here's one view of some national climate and health efforts. The highlighted locations are grantees in the Climate Ready States and Cities initiative. So these are our peers across the country. As I said, there's 16 funded states, 2 cities, New York City and San Francisco, for a total of 18 projects, plus 7 tribal nations, which I didn't add in here, but just to know that there are other communities out there that are more at risk, more vulnerable, more in need that are being worked on. So a little over 24 projects to collaborate with CDC to assess and intervene at the health level. And a summary of these projects can be found on the CDC webpage. So how do these CDC projects approach building resilience? Next slide. This is that brace graphic you saw earlier and you heard Ned talk about. So what is our model for intervention? It's a little different than others. It's a framework for assessment and intervention. We're really trying to measure changes in conditions and changes in health outcomes. That can be complicated. Janine's going to talk more about these individual steps at the local level, but at the state and national level, obviously we have to forecast the climate impacts and work with climate scientists on that and assess vulnerability to the population. And then step number 2 is probably the most challenging part, projecting the disease burden. You can imagine that the different data sets that are out there have different temporal and spatial values for them that are often hard to link up, and you'll hear Dr. Bush talk about that. So state data we can often get, and it's fairly high quality, but it can't always be compared easily to other states. And local data, because it's a much smaller population, is less available because sometimes it's hard to actually get the statistics to report down to that level in an accurate way. So what's our key message kind of coming out of this? And kind of maybe our elevator pitch, thinking about how we apply this and look at it from the Northeast perspective. So we'll go to the next slide. Oh, sorry, a little blip there on you are here, as in we're kind of right at a step between steps 4 and 5. So yeah, thank you very much for coming back. So we are here. We've developed a lot of the plans and we're working on doing the implementation. I think it's helpful to have some kind of key messages or simple things we can say. I think for us, experts agree that the Northeast, go ahead and advance, is getting warmer and wetter with more severe weather and sea level rise, and all these changes may result in human health impacts. Remember, these changes vary from region to region. Compare this message to that for California, right? It's getting warmer, it's getting drier, with maybe some severe weather, depending how you look at wind and wildfires there, and maybe less significant sea level rise. Weather conditions in the atmosphere, so winds may be driving those wildfires, as I said. So 2 very different approaches. In the future, it looks like the Northeast is going to be very water abundant, and other parts of the country won't. So let's segue to the next slide and talk about what the state of New Hampshire is doing to address climate and health issues. So kind of similar to the state level, we try to provide leadership via multiple programs. We engage with our partners and have a stakeholder group that meets periodically. We train the health and environmental workforce at the state level. We track data, analyze, and try to post this data to portals so people can access it. We gather new data, analyze, and try to publish the results. Right? So that's some of the basic things we do. We also are involved in assessment and interventions. We assess environmental conditions and health facts for both atmospheric and hydrologic conditions that are changing in the Northeast. Or I should say we work with partners who are doing that. And then we do interventions to actually change the conditions which people live within and try to build some level of individual or community resilience. And then we communicate findings to our stakeholders, and we try to inform policy change. We don't actually do policy change directly. Remember, as state government, we're part of the executive branch, and that's the job of the legislative branch, but we try to inform and really get people the best information that they can do. So these aren't actually advancing quite right, so I'll try to do better about click or next or better pause. So we complete all these projects with one part-time manager and one part-time epidemiologist. That's me and Dr. Bush. And we have, of course, some resource challenges there. So let's look at some specific examples of our projects, and you see our map popped out there. And we'll look at past assessments first. So as we click down the list, you can see we've worked with UNH on atmospheric projections. Then we've worked with USGS on hydrologic projections. We've worked with Plymouth State University on weather and injury trends. And we've worked with UNH and our Department of Environmental Services in the Great Bay looking at the conditions there and oyster bacteria levels, which you imagine would be important for foodborne outbreaks related to shellfish. So we've worked on trying to get a good picture of how conditions are changing in the Northeast, or New Hampshire, I should say specifically. And on the map, you can kind of see a number of different examples of those projects. I think if you focus in on the blue font, you'll see kind of in Concord, that's the center of our activities where we kind of bring in resources and try and provide guidance. And our two main interventions right now that are active are in the Southwest. We have the Monadnock area working on severe weather and resilience, especially in older adults and vulnerable adults. And then over on the eastern border, we have the Seacoast area working on tick habitat with outdoor leaders. Obviously, tick habitat, tick-borne illnesses, and working with outdoor leaders, so another at-risk population. In the past, we've worked on three others, the Lakes region, and then the next is Upper Valley and the city of Nashua. In the Lakes region, we also worked on tick habitat and outdoor leaders. In the Upper Valley, we worked on heat stress in elders and isolated rural adults. And the city of Nashua, we tried to work on heat and exposure in inner city population. So there we tried to get a little closer to that issue of climate justice. Why are inner city people more at risk? Well, they're obviously the heat island effect of being in a highly paved area. There's older housing, which doesn't cool as well. And there's also institutional disadvantages and poverty, which make them more vulnerable. So we'll go on to the next slide and take a look at two ongoing intervention projects. And this is a quick list we can look at. As you click through, it'll say the Monadnock, which is severe weather, and Seacoast, which I've already mentioned. So we can go on to the next slide. So here we are talking about the greater Monadnock area, weather impacts and resilience among older adults. And I just want to emphasize here three interventions to increase knowledgeability and awareness of the cause. Each of these three, and we'll start off with training of older adults, really is kind of, we have evidence-based material that says if you can work directly with older adults, we can improve their knowledge, skills, and abilities to respond to these. Number two, the next one, is support to build an emergency kit. So you have to have the knowledge, and then you also have the ability. You have to have a kit which is watertight, which you can store somewhere in your home, which has a flashlight, which has an emergency first aid kit, which maybe has some emergency supplies, water, food, radio, and maybe some of the medications you might need to get through 1 to 2 to 3 days or longer of being isolated. And the third one, next click, is community information campaign. So we're just beginning the design of that. The idea is how do we outreach and raise awareness and maybe even build resilience through that awareness within the community. I won't cover much more here, and I'll let Janine cover this project in more detail after I finish this up. You may recognize this photo from the neighborhood. Oops, sorry. Go back one. So that's a neighborhood in Keene, New Hampshire, which flooded in 2005 and 2006. This is ironically on a place called Water Street in Keene. So that's one familiar photo. If we move on to the next slide, we'll talk in a little more detail about another project on the seacoast, insect habitat and tick-safe practices among adult caregivers. You can imagine insect habitat is changing for ticks, right? There's less snow cover in many areas, so there's less chance for ticks to dry out and die over the winter time. There's warmer, wetter conditions. There's a lot of things that drive and make ticks survive better. So we try to think about the habitat side. And then we try to think about tick-safe practices that we can do specifically among adult caregivers. So we came up with 4 interventions, I should say, the grantee in the Monadnock area with collaboration that came up with these. Basically, if you click to the next one, you'll see it begins again with training of summer camp and YMCA staff, specifically adults, because the evidence-based literature shows that it's more effective with adults. There's also a training for healthcare providers, so people who actually work with people who've been affected by some of these tick-borne illnesses. Next is number 3 is tick habitat assessment and control. So that's where we actually go in, have some people from UNH Cooperative Extension do tick drags, where they try to pick up and understand what are the heavier areas with more ticks in them, and then either try to landscape, label, or somehow control that environment so people have less exposure. And then next, number 4, policy change for insect repellents. You can imagine a lot of people are concerned about the use of repellents and sometimes think they're more dangerous than the actual illness. They are not. They're safe and effective, as proved through many, many studies, if used correctly. So because of this kind of resistance to use of insect repellent, we're trying to encourage camps and summer camps to change their policies so people can more easily opt into using them, and they can learn about the safety of those. So just to talk a little bit about the methodology that was in this project, and you can say in this, you can flip back before we go on. So the methods were based in past experience and a review of the research literature, a very extensive review of what works best. And we're still learning a lot about how to best prevent ticks. We don't have a lot of large population studies on how to do that, but we're getting there. The other thing we did is engage with local health advisory council on the seacoast, tried to find out what their wants and needs were. They prioritized habitat change, tick exposure, tick-borne disease among youth in summer recreation programs as a big priority for them. So we decided on an intervention via education of adult staff at YMCA after-school programs and 85 young adult camp counselors for a total of about 115 participants. The intervention was a 45-minute lecture and demonstration of tick-safe practices, but there was no direct education of youth in that, the actual affected population. We'll talk more about that later if you'd like to, but just the research literature shows it's much more effective training adults. And last, the evaluation pre-post testing showed a rise in staff knowledge of 25 to 80%, depending on which area of knowledge, around symptoms, tick habitat, tick species ID, and also something important that I think Janine will talk more about, belief in the ability to teach others or readiness to act. We thought that was an important measure to ensure that we were going to be successful. So next slide. Lessons learned, really 3 basic ones. The community engagement, or the process of community engagement and plan development, were significant investments of time, weeks and months, and viewed as an important to the success of the final intervention, especially in innovative programs that really have to get out to the community and find out what's wanted and needed. Second, the intervention findings showed limited change in knowledge, skills, and abilities and behaviors, yet a good test of the methods and kind of a helpful understanding for what we get for our invested dollar. And third, we identified a need to improve, to implement fewer projects with more focused resources. So the first cycle was 4 intervention projects at $20,000 a year for 2 years. Now we're down to 2 projects at $40,000 a year for 2 years. So we're really trying to focus in and apply this so we can do better intervention and evaluation of the results. We can go to the next slide. That's pretty much it for my presentation and background. I hope that was helpful. It's always hard to fit 6 years of experience into 15 or 20 minutes of presentation, but I'll look forward to the question and answer process where we are able to maybe talk more about your concerns or questions.
Thank you, Matt. And in the interest of time, I'm going to go ahead and tee up the presentation for Katie. And while doing that, I will remind people to go ahead and put your questions into the question and answer panel so that we can have a lively discussion following this presentation. So now we're going to hear from Dr. Kathleen Bush, who, when she's not wearing a white lab coat and pen protector, I believe goes by Katie. She's the program manager for the Environmental Public Health Tracking Program at the New Hampshire Department of Health and Human Services in the Division of Public Health Services. She also supports the Climate and Health Program. Her work focuses on the human-environment interaction. She has a background in environmental epidemiology and draws on a variety of statistical and geospatial methods to evaluate trends in health outcomes across space and time. All right, go geography. She's committed to building environmental health capacity at the state and local levels. Kathleen completed her PhD in 2011 in environmental health sciences at the University of Michigan School of Public Health, where she was also a Graham Environmental Sustainability Doctoral Fellow. With that, I'll turn it over to you, Katie. Take it away.
Great, and I'd just like to echo Matt's sentiments of having us today to share our work with a broad audience. So you can go ahead and advance to the next slide. I'm going to talk about a specific study where we're linking exposures to health outcomes with the ultimate goal of identifying high-risk areas to better target our interventions. And I do just want to take a moment to talk about the Environmental Public Health Tracking Program, which is another CDC-funded program. We work very closely with the Climate and Health Program that Matt talked about. And you can see up in the right-hand corner here all of the shaded states that are part of this program. There are, in fact, 26 jurisdictions. I believe almost all of them are also included in the Climate and Health Program. So a lot of great opportunities to collaborate. And our program is really focused on integrating data. You can see there integrating hazard data, exposure data, and health effects data, doing a lot of analysis of that data, and then most importantly, that center arrow, sort of the dissemination of that data to stakeholders and partners to really drive local action and improve public health. So the study I'm going to be talking about, go ahead and advance to the next slide, is a regional collaborative that was actually completed a couple of years ago, but continues to inform now the work that we do. So if you recall the BRACE framework, one of the key steps is to investigate really the disease burden and the link between those hazards, exposures, and outcomes. So this study focused on the impact of heat on health and how we can translate data into action. Specifically, this work focused on lowering the heat advisory threshold to better protect public health, and it represents a collaborative effort across multiple states and Brown University. So we had collaborators at the Rhode Island Department of Health, here in New Hampshire, and also at the Maine Center for Disease Control. Next. As many of you know, heat is a major threat to public health. But there is some limited, or at the time of this study, there was some limited information on the risk of ED, or emergency department visits, so sort of those non-fatal impacts. We also had limited information on the effects in the Northeast. And as many of you have probably seen in the literature, this work tends to focus on large metropolitan areas, often in the South or Southwest, or even the Midwest. And so there was a lack of evidence specific to the Northeast and some of these more rural areas. And so one of our goals was really to sort of fill this void with some local data. And we were really focused on trying to understand the impact of heat exposure on both illness and death, or morbidity and mortality, with the ultimate goal of trying to inform local action and potentially lower heat advisory thresholds. Next. Our key research questions were to better understand how heat index impacts health, whether or not the current heat advisories were optimal for protecting public health, and what could we do at the state or local level to help reduce that risk. And so for those that aren't familiar, the National Weather Service issues, oh, go ahead and go back for a second. The National Weather Service issues a number of heat products, and heat advisories is one of those. And often it's sort of the decision point for mobilizing resources and emergency preparedness resources. And so we really sort of focused on that as a trigger for action at both the state and local level, where we would see a mobilization of resources to get the message out, reduce that exposure, and try to protect public health. I just want to highlight the map here. This was the study area for the Northeast Heat Health Analysis. You can see that about 10 study locations were included. I'll talk in a minute about the data, but weather stations at each of these sites provided the weather data, the heat index data specifically, and then we used population data and also hospitalization data in a 10-mile buffer. And so one of the challenges doing this work is to link exposure data with health outcome data in meaningful space and time. And so this was our attempt to link people to a meaningful exposure, sort of assuming that the weather in a 10-mile area would be representative of what those people were experiencing. And again, just to highlight, we have sort of a broad range of geographies here. And while much of the state perhaps was left out of the analysis, we did in fact capture about nearly 2.5 million people in this analysis, which is, I think, nearly 3/4 of the population of all the states combined. So really, we were able to capture sort of high density, high population areas, which of course helps just with understanding the impact where populations live. In the next slide, I'll talk a little bit more about the data. So our study really focused on, it was sort of a retrospective analysis, looking at what we would call the heat season from May through September. Different states had different years of data available, but we pooled it all together. As I mentioned, we defined our study areas as towns that were included in 10-mile buffer around weather stations, and this represented nearly 3/4 of that entire state population. The exposure of interest in this study was daily maximum heat index, and that goes back to the fact that, again, where we were interested in influencing when the National Weather Service issued a heat advisory, and that is based on a heat index. So there's lots of work out there looking at lots of different exposures, you know, nighttime lows, maximum temperatures, diurnal variations. But because this study was really at the beginning, at the onset, was interested in impacting heat advisory thresholds, we focused on using the exposure most relevant to that decision. And then our outcome of interest were daily all-cause emergency department visits, so going to the emergency department for any reason, as well as some heat-specific causes, and also all-cause deaths. So again, sort of looking at some of the less severe outcomes all the way up to the most severe outcomes to better understand the overall impact of heat on health. Next slide. I'm going to move pretty quickly here through some data. And I'm happy to talk more during the Q&A session. So jumping right to some results, this is sort of an overall picture of what we found across the region. To orient you to this graph, we sort of have a risk ratio, or the risk of going to the hospital on a 95-degree day compared to a 75-degree day as a function of heat index along that x-axis. And you can see that your risk goes up as the heat index goes up. And in fact, that risk increases by 6.5% on a 95-degree day compared to a 75-degree day. And then what's perhaps most interesting, again, sort of tying the data back to that decision, looking at where the red shading is around 100, historically, that's where the National Weather Service would issue a heat advisory. And so what we took away from this is that there was lots of room for improvement, where we, in fact, were capturing health effects at more moderate heat index temperatures. And so we shared these results with partners in the emergency preparedness sector and also our National Weather Service partners representing all the states involved to really talk about, could we lower that so that we're mobilizing resources sooner, since we in fact are capturing an effect at temperatures or heat index values, you know, in the 80s and even 90s. So just keep that in mind as we go forward. Go ahead and look at the next slide. And another interesting finding was that we did in fact see some variability in that risk across locations. So the squares here represent states. You can see Rhode Island in blue, New Hampshire in red, Maine down in purple, and then within that, some of those more smaller study areas within each state. But what's interesting, when you move from Rhode Island, New Hampshire to Maine, essentially moving south to north, we do see an increase in risk. And so we can hypothesize perhaps some underlying causes, perhaps populations are older as you move north, perhaps we're less well adapted with less access to air conditioning or housing structures that are less built for heat and really more for cold weather. There's lots of potential reasons. We don't know exactly why, but this information, this local information, is important when designing interventions. Go ahead to the next slide. It's also, again, as I mentioned, important to think about the range of outcomes. So we can think about all-cause admissions. Are you going to the hospital for any reason on a hot day compared to other days? And we see about a 6% increase in that risk. What we found quite interesting in the Northeast region was that your risk of heat-specific outcomes, so dehydration, heat stress, that was nearly 80% higher. So really a much higher risk of those heat-specific emergency department visits. And then also interesting were those increased risks there in renal and also asthma. So again, thinking about using this local data to really help identify vulnerable populations to better target an intervention. Really, this local data can help inform that type of action. And then just a couple other things of note. Often there's interest in whether there's different effects in the early season versus the late season. In this study, we saw no effects, sort of comparing spring and summer. Also no effects across males or females, and really no significant effects among the general population compared to the elderly. But again, this is just one study, and I think a lot of that could be attributed to maybe while we were able to pull data across states, we still did have a relatively low sample size. So with a larger pool of data, we may have been able to tease out some differences here, but I think a takeaway is that you're at risk of heat all summer long, no matter your age or your sex. And just to wrap up then, to summarize these results, and then I'll talk a little bit more about sort of how we use this data to inform action, thinking about a day with a heat index of 95, so really pretty moderate day compared to a 75 day. Your risk of all-cause ED visits in the Northeast increases about 6.5%. And this is really over a 1-week lag. I mentioned the heat-related ED visits, your risk goes up closer to 90%. And your risk of death for any reason also goes up nearly 6%. So the key point here is that we were able to capture health effects occurring at more moderate heat index values. And at the time, those were below the current weather service threshold for issuing a heat advisory. And so next slide, as I mentioned, we worked closely with our weather service partners in multiple offices to evaluate the thresholds for issuing these different heat products. And that right there on the left, the heat advisory historically was issued at a heat index value of 100. But after this work and multiple meetings and a lot of support from national and state partners, we were able to come to agreement to actually lower that threshold to 95, so that now we are starting sort of the emergency response protocols in many states and many jurisdictions at 95 instead of 100. And the groups are all sort of still evaluating the impact. I'll talk a little bit more about sort of the work that we're continuing to do since this change last summer. And just to summarize the differences on the next slide, you'll see a map here. Back in 2016, all of the Northeast was issuing a heat advisory at 100, and you can see more recently those most northern Northeast states are now issuing a heat advisory at a temperature of 95. And some of you may scratch your head and say, well, what about Connecticut or Massachusetts? And I think what's important to think about is when making these sorts of decisions, there's always sort of a cost balance, cost-benefit analysis, and you need to really balance the number of warnings against reaching your intended audience. And so the reality is, with many more people and more urban areas in Massachusetts and Connecticut, there was worry and concern that they'd be issuing too many warnings and And there's a term, sort of warning fatigue, and so would the message really be diluted over the course of the summer if we had to then issue many, many more warnings in some of these jurisdictions? And so it was sort of an interesting lesson for me as someone often just on the data side, but thinking about trying to put this data into practice and the trade-offs then of those decisions. And we can come back to that during the question and answer session. So I'd just like to sort of wrap up by saying that all of this local data can then inform work that we do. And we've been working hard at the state and local level to integrate these findings into heat response plans, as well as hazard mitigation plans, and many of the climate and health adaptation plans and interventions that Matt talked about earlier. Because with this local data and information, we can better understand place-specific risks, those vulnerable populations, and better design our interventions to target those places and people. There's a few other tools I just want to make sure that you're aware of. Sort of as the State Health Department here in New Hampshire, we work hard to make sure that data are available to partners and stakeholders. So one of those is the New Hampshire Social Vulnerability Index, which is very similar to a similar tool put out by CDC. You can see the link at the bottom or find this on the New Hampshire EPHT website. But it's a summary of vulnerability at the census tract scale. It combines 16 measures to then summarize overall community vulnerability. So you could imagine how you might take results from the study and integrate it with this type of data to really sort of target vulnerable areas. The second tool on the next slide is our Wisdom Data Portal, where this is really the home for much public health surveillance data. There's information on all kinds of health outcomes, asthma, injuries, heat-related illness. On the next slide, you'll see within the tracking portal specifically, there's a section on climate change. And there's definitely some work to do to sort of build out these modules and add more indicators. But there is currently data on heat stress. And we've also talked about maybe incorporating cold-related injuries and illness in the future, recognizing that that too is a hazard here in New Hampshire. And so with my last slide, I'll just sort of highlight that the work I talked about today is really a regional collaboration, and the work within the tracking department and the climate and health program is collaborative, multi-state, multi-sector, and here's just a quick glimpse of many other projects happening across the region if you want to learn more about sort of what's happening maybe in a different jurisdiction or area. But it's really quite rewarding to be part of both these national and then regional initiatives, and we're, again, thankful to be able to share this work with you today. Thank you.
Thanks very much, Katie. And I've left your, I'll leave this slide up for just a moment so people can jot down your email address in case they have any questions. If you didn't get this in time, know that you can you consult the recording to get Katie's contact information. She also has some references she's included. We're going to move on to the last presentation and then take all and look at questions at the very end. In the interest of time, we want to make sure that we get everyone's presentation covered today. Our next speaker is Janine Marge, who is a PhD student at Antioch University, New England's Environmental Studies Department. She began working with the Center for Climate Preparedness and Community Resilience in 2018 as a graduate research assistant for the Building Resilience Against Climate Effects project with the Greater Monadnock Public Health Network in Cheshire County. Janine conducted research and facilitated stakeholder sessions to produce a literature review and theoretical framework that assisted community partners in the creation of a pilot intervention. Initiated in the spring of 2019, the BRACE project used the trans-theoretical model of behavior change and combined educational sessions with emergency kits and support networks to build resilience against extreme precipitation events within the over 65 population. And if it was a mouthful, just know that she's going to cover that, all that material in a few moments here. The results of the project intervention will inform a similar project throughout the region in 2020. With that, I'm going to give the microphone to you, Janine. Take it away. Thank you.
Thank you, Ned, and welcome everyone. I'm really excited to share with you what happened here in Southwest New Hampshire, so that if you are looking to build a project like this in the future, hopefully you'll gain some insight into what we did. And I do want to say that probably the biggest gift of the initiative was the fact that there was community engagement throughout the process, because it was created by the people locally for the people locally. So next slide.
You should be able to advance the slides yourself, by the way, if you...
Yeah, we're trying that now.
Uh-oh. Okay, I'll see this back up for you.
Okay, so what happened is, I want to show you the first slide that is about the brace model that Matt had talked about earlier. And I want to show you what we did with that particular model in the Monadnock region and how it was developed using that model, what we ended up doing physically on the ground. And through a lot of research, we came up with extreme precipitation as the event that we wanted to target, because we had a really bad flood in 2005 that wiped out one of the local towns, and then we had an ice storm in 2008. And then from 2010 to 2013, we had a variety of floods. We had a hurricane in 2011. So there were a lot of different precipitation events that really affected people in the area, particularly the older adults. And next. So we also looked at what are the disease burdens that occurred in this area with older adults in particular. And we were looking at potential contamination of food and water supplies, carbon monoxide poisoning from the use of generators inappropriately, and potential for mold-borne illnesses where people actually would be having to leave their homes, and then drownings, death, and other injuries. Next, please. Assessing the public health interventions, we went through a lot of the research, not just through the CDC and Department of Health and Human Services, but basically globally, and looking at the different interventions that ranged from building rain gardens to support systems for neighborhood watch programs, all the way through to emergency preparedness programs. And the literature was very supportive of emergency preparedness as the way to go to help improve the resiliency of individuals and the communities. So we then, next please, used all that information to inform our CHAP, or Climate and Health Adaptation Plan, and our pilot intervention, which took place this past year, next. And we are currently using the evaluation of that pilot plan to inform what we intend to do in 2020. Next slide, please. So our partnership began with 4 individuals: the Greater Monadnock Public Health Network, which is an organization of various service agencies within the region, from medical to the hospice to housing to transportation, and all of those organizations together with Department of Health and Human Services, Southwest Region Planning Commission, which kind of spearheaded this entire project, and Antioch as the academic partner. Next. Here we go. Okay, so the challenges that we had in putting together a program for this particular area is that we have an aging population in the Monadnock region, and from around the beginning of the century, we were somewhere around 15% of the population was over the age of 65, and by 2040, we're expecting 26+% of the population, more than a quarter of the population, will be over the age of 65. So that's going to be affecting the housing, the transportation services, the medical services, and the social service needs of the area. Next. Okay. We also have extreme precipitation events that occur throughout the year. In the wintertime, we will have heavy snowstorms or heavy rainstorms followed by thaws, and then we'll have floods in the spring, and then we have hurricanes. We had a huge snowstorm on Halloween several years ago, and we just recently had between 2 and 3 feet of snow that consequently melted and caused flooding in December. We are very, very local, so next, being in a very rural part of New Hampshire, we rely heavily on volunteers for social services, but also for emergency services, especially some of the first responders and fire in particular. Next. The biggest concern that we have and biggest challenge is that there are many misperceptions about disaster response. And that includes how long do you believe it will take first responders to actually arrive? A survey was done in 2017 in which 40% of the people felt that emergency services would be there within an hour, and more than 80% felt that they would be there within a day. And in reality, it's usually at least 3 days. And during our ice storm of 2008, I was without power for 10 days, but other parts of the state, or in this region in particular, were without power for over 3 weeks. Next slide. The social vulnerability index that you saw earlier today was used to inform our climate and health adaptation plan. And the darker the color, the more vulnerable the areas are. This particular picture shows you tick-borne illnesses coupled with heat stress and extreme weather. So what we did for this area, we took a look at who's the most exposed to the extreme weather event. You can hit the next piece, please. So we're looking at extreme precipitation and weather. Who is most sensitive and who has the least ability to adapt to those changes? Those are the people that are most vulnerable. Next, please. And what we found was people living near the rivers or in community housing, elderly housing, typically in low spots along the rivers, were at highest risk. A lot of those people had health issues, and anybody who was in an area that did not have a car or did not have the resources to physically leave the area prior to a hurricane coming into the area were at highest risk. Combining all those factors together, we have next. We have 5 towns that come up as being the most vulnerable in our region. So those were the 5 towns next that we targeted with our pilot project, and the objective was to increase the level of individual resilience to the stressors of extreme precipitation. Next slide, please. We held a series of stakeholder sessions within the community, and we held them at different days, different locations, and different times of day to try to get as many people to come as possible. We found a lot of people were really interested in these conversations. The overarching question that we asked is what programs or tools would reduce health issues caused by extreme weather events? And within that, we had smaller conversations about, tell us about your experiences, what went right, what went wrong, what could you have used to have made things better? Next, please. And what we found was by inviting the council, the overarching council, next. It should be scrolling down on its own. Automation, keep going. We invited beyond our community partners, we invited emergency responders, fire chiefs, people that worked in nursing homes and were visiting nurses. And then in white, we invited people that we consider to be the population at highest risk. And in those, from those places, we found the best way to have community engagement and impact and insight and contributions was to hold the sessions about an hour before a community lunch. And by doing that, people were willing to come in and tell us all of their horror stories and what's happened over the years. And I have a ham radio, so I'm all set. And I have a flashlight, so I think I'm okay. And then they could have a community meal. And we got lots and lots and lots of information from them, and then they wanted us to join them in their meals so they can continue to talk about the subject because they found it interesting and they found it very important. Both different groups, the helpers on top in black and those who occasionally need help in white on the bottom, had the same big issue that we need to address in this area, and that is if we are putting into place emergency shelters in different towns, we need to have emergency shelters that will accept pets. Because we heard so many people say, I will not leave home without my pet. We need a place where I can go with my pet. If my pet can't go with me, I am going to stay here. Next slide. After all of the stakeholder sessions, we gathered all of the data from what people had said, and then we went back to the literature to look at the top 6 interventions that had come up as potentials for the area, including the rain gardens, the emergency personnel training, early warning systems, neighborhood watch program, a local registry, and emergency preparedness training. And while all of them came up in conversation, every single session, there was support for emergency preparedness training, and there was some support for the early warning system. So we decided to combine the both of those with emergency kits to put together a training sessions, or a series of training sessions in the area. Next slide, please. In 4 different towns to educate people over 65. And what we did to determine whether or not we were making any headway as far as behavior change is we chose the trans-theoretical model of behavior change. And you can scroll down through all of these, please. And what this is a scale, a fluctuating scale. People move in and out of these different levels from, I don't need a plan. Well, I think I will make a plan maybe in 6 months. I'm going to do it this month. To the action and maintenance stages, which is where we want everybody to be. I have a plan now, and I have a plan, and I'm going to keep it current. And that was really our goal with the workshops beyond the education, is to get them to have a plan to be safe. Because one of the comments we heard from the first responders is that sometimes we have to leave people to go to another call, and these people really should not be left alone. Next slide. The results of the training, we had 60 people attend. We were hoping for 100, so we gave out 60 emergency kits to people in the area. Again, these are all people that live rather remotely and that we felt were at risk. When you look at the graph, how prepared do you feel for an extreme precipitation event? In blue is the survey they took the day of the workshop before the workshop started. In orange, it's the response immediately after the workshop, and you can see that people were really jazzed about the workshop and they felt much more confident. And then in gray was 8 weeks later, a mail-in response questionnaire asking the same questions. So even though we did not have as many responses to compare, you can still see that there's a bell curve putting most people in the I feel kind of confident. And I feel kind of prepared. So if you can click on the next piece for me, please. The next question, which goes back to the TTM model of behavior change, which phrase describes you in relation to emergency kits? And these were kind of all over the place, but again, after the workshops, they were pretty excited about them because they'd just been given this wonderful kit with a bucket and a blanket and first aid kit and emergency contact list and all of the goodies that went into it. And when you look at the gray, again, you have people that are preparing it and planning to prepare it in the near future, even 8 weeks after the event. So even though the research, the literature will tell you about 6 months after an emergency preparedness training, a lot of that information gets lost. Even 8 weeks afterwards, there was still some interest in this particular program. Next slide. One of the things I want to leave you with are some of the thoughts that came out of the sessions, especially when we're thinking about how to engage people from first responders and the helper side of things to the people that need help but don't necessarily know that they need help. And one of the comments that the first responders came around with many times was, we need to empower citizens or communities to help themselves, and we need to teach people not to be victims so that we don't have to rescue them. And that goes right back to the fact that a lot of these local communities are volunteer oriented, and their resources are stretched very, very thin in some of these disasters. A lot of people said that a lot of people don't have backup generators for oxygen, and they don't know how to refrigerate their insulin. We heard that time and time again. So many people said, I don't know who to call to get help. I don't know where to go. I don't know what to do when the power goes out. And we're hoping that through training sessions like this, we can help alleviate some of that confusion. My favorite quote, which is very visual, is, what convinced me to leave my house was a boat came by my window. And when you stop and think about that, does this person not know that there's a problem? Does this person not want to leave the house? What's going on? I don't know, but that's just a very, very visual comment for me. The one that scares me the most is the one that seems pretty normal. It's a very, very universal comment, and it's one that comes up in a lot of the literature, that no one identifies as having needs until a problem occurs. The one I put in the middle because it doesn't really stand out on its own until you stop and think about it. And in the literature, there are a lot of people around the world that don't think about emergency preparedness until they experience a tsunami or a hurricane or something, a devastating wildfire, and then they start to think about emergency preparedness, and then they're ready. But they don't stop and think about it beforehand. And a couple weeks ago, I went and spoke to Retired Teachers Association in this area. And when I got done, the attitude was, well, we don't have emergency kits. These are all highly educated people, very compassionate people. We don't have emergency kits, and well, we might need to be dealing with that someday. That might be happening to us. So not even seeing that that could be happening to us right now. They're not identifying as having needs because a problem has not occurred yet. So I want to leave you with that thought, turn you back over to Ned, and good luck with the projects that you're going to be working on.
Thanks so much. I am going to transition to show you a picture of our presenters here. I hope you can see it. And we're going to take a few questions from, oops, excuse me. There we go. Can you see my screen? I hope so. I'll invite the speakers to all unmute themselves. We're going to take a few questions at this point. We did have a question about, someone saw your slide, Matt, of about tribal issues and wanted you to talk a little bit more about that. So I'm going to go ahead and put up these slides. We kind of scanned right past those. Let's see. I'm looking to get that person's question out of the chat window, but perhaps you could speak to this. The question was, how can I get more information and the map about climate-ready tribes?
Okay. If you do a web search for climate-ready tribes or climate change in tribes, it should pop up very quickly, but I will work on getting that specific link for you. As I said, CDC Climate Ready States and Cities program had a small grant that they began about 2-3 years ago to get tribes back on board, because they're really at the forefront of climate change. A lot of them have subsistence living, certainly eating and fishing, and they often live on marginal lands, which are more affected. So it was a great idea for CDC to put that together. So that's kind of the first thought. This specific image they have up right now is just examples of challenges and impacts nationwide. So these aren't examples of actual CDC or other programs that are funded, but as you can imagine, looking at the Pacific Northwest, their challenges really are in salmon habitat, because it provides such a lot of food for the people there. And it's more than that, it's really a cultural identity around the food source and the migration and the challenges that are there. So people probably seen that show on TV called The Years of Living Dangerously with Leonardo DiCaprio. He went to Alaska, actually with some folks from the CDC, to the community of Wainwright, which is often featured on news programs because the shoreline is eroding due to lack of permafrost and just more severe storms that are occurring there. So those are two examples kind of right off the bat of them. There's also, as you can see here, the Southwest has threats to food and tourism because that's important to indigenous communities at times. The Great Lakes has invasive species problems, and Katie lived in the Great Lakes and might have a perspective on some of that. And Florida has challenges with continued subsistence agriculture with droughts they've had there and changes on the land. So I don't know if I can answer it more specifically. I don't have expertise in this area, but I've just heard about it through some presentations and work over the years.
Okay, that's fine. We'll take a question for Janine here. How did you narrow down the 5 factors: low income, mobility issues, heat issues, and community housing? How did you come to choose those particular factors for evaluating vulnerability?
There was a lot of research that was done using the Department of Health and Human Services information, as well as what Ned talked about with the U.S. Climate Toolkit. And that was all part of the Climate and Health Adaptation Plan. That part of the research I wasn't involved in specifically, but going through what the state had done and with some of the toolkits, you could go into a lot of this particular research and find what was considered to be the biggest hazards for a specific region of the state. And looking at economic factors, looking at the age of the population, looking at the education of the population, and putting all of those factors together, there are a lot of spots in the Monadnock region where it's not only elderly people living in community situations or people who are living along low-lying areas along some of the rivers that dissect this region, but there's also a lot of lower income people in the area, and we do have some homeless populations. So when you combine all of those together, that helped to create the vulnerable populations within the region. And then I then took it and focused specifically on, in those particular spots, which ones are most likely to be affected by extreme weather events.
Okay, thank you. We have several questions, Katie, regarding vulnerable populations and the Social Vulnerability Index. One person is asking about factors such as race or environmental justice or exposure due to poverty. Could you speak a bit more about socioeconomics in the context of social vulnerability, and also maybe review how those factors were really correlated with the capacity to adapt? Maybe review your framework there. There are a few other questions related to that, but let's see where that goes. And if you could keep the answer rather short, what we're going to do in a moment is wrap up, but we'll continue the Q&A session after the official ending time of 1:15.
Sure, I'll do my best. So the Social Vulnerability Index tool that I shared is limited to just 16 metrics, and I think we all know that many of those metrics are correlated: income, education. So I think it is challenging to maybe identify those leading causes of vulnerability, but all of these tools are really just screening tools. And I think the strength of these types of projects is the local knowledge and expertise then that the stakeholders bring to really help identify those populations most at risk. So I think that's an example of where those vulnerability factors are going to vary place by place, community by community. And it's important that you really work with local partners to best understand who is at risk and then develop the appropriate intervention. And these tools are limited in that they only show certain metrics at certain scales. You know, one thing we've talked about here is that what's in fact interesting is how those factors are changing over time, and whether income is stagnant or ethnicity and race are changing, or are populations just aging, or is there also an influx of younger? So looking at some of those change metrics, I think, can also really inform what we might call the community characteristics that then inform development of those interventions. I hope that answers the question. Certainly social determinants of health are a complex issue.
Yeah, so and there's quite a bit of literature available. I'd say if you have a persistent question about that, get in touch with one of us, either through the emails that we've provided or through the Climate Resilience Toolkit. We're happy to address your questions. Briefly, here are the email addresses that you'll want. And also, before we close, I want to mention again to save the date for the next webinar, which will be on February 27th. So you can register at the URL that's on screen right now. And if you need to go, we understand, but we're going to continue the question and answer session right now for as long as it takes to get through these questions. It shouldn't be too long. So we welcome people to stay on, but know that we're recording this and we'll post those questions and answers along with the rest of the recording. So Matt, how was success evaluated in your training programs?
So we have a pre and a post test that we do with all of our training programs, and it's challenging because, right, you know, I mentioned that I was an EMT and was a trainer in wilderness medicine previously, and there it's fairly straightforward. We have a lot of really well-developed competencies for how you maybe set a broken bone or deal with a burn or do those things. And they're taught all around the country and refined and improved. We really don't have that yet for emergency preparedness. We don't have it for tick-borne disease. A lot of these things, we're not sure to what level of expertise or competency we should train people up. So what we do is a simple 1 to 2 page pre-post test that basically says, what's your level of knowledge of this particular topic area? What skills you possess? And then you have the ability, readiness, or confidence to perform a particular new behavior or a new activity. That's where we start, but I wish that someone around the country had already produced wonderful pre-post tested tools that we could use, and they're not quite there yet, so we're at the beginning of developing those. Outside of the kind of pre-post testing success is kind of when I said lessons learned. After we complete a project, we sit down and go, okay, what did we do well, what could we improve? And we try and integrate that to the next phase of our development.
Okay, this question comes from Kyle, who has left the webinar at this point, but wanted to know, and this is for all of you, maybe we could briefly touch on, do you ever get calls to participate or advise in activities outside of very specific public health and epidemiology professions? For instance, are activists or community planners, other decision makers outside of public health interested in the work you're doing?
I think this work in the Monadnock region, this is Katie Bush talking, the work in the Monadnock region is a great example, I think, of the integration between planning and public health, actually. So the Southwest Regional Planning Commission has been a very active partner in this from the beginning. So I think, yes, we see sectors other than public health interested in this work and really active at the table. I don't know if anyone else wants to speak to that.
Sure. The easy answer is yes. We get lots of requests for assistance in these areas. Other state agencies like Homeland Security come to us, Environmental Services, often asking us what insights can we provide on the impact of air quality on health and more specifically those climate hazards and weather hazards in health. And we do our best with the amount of data we have. Remember, you said it's complicated, trying to tie those together. And we also get a lot of calls from advocates. Every couple of months, somebody will call in, someone from Moms Clean Air Force or the New Hampshire Public Health Association saying, can you come to this rally or this discussion or this meeting and provide a perspective. And we can usually do that from a kind of scientific and programmatic perspective, but we're always cautious not to get into the advocacy side. So we like to provide a balanced presentation and try and help people understand the challenges of associating these climate and environmental exposures with outcomes.
And definitely tricky business.
I can add, Ted.
Go ahead, Janine.
One more comment that is kind of from left field. As a master gardener, I'm asked to present on a variety of topics, and the last couple of years I've been asked to present more and more on climate change and what that is doing to the gardens, what that's doing to the flower gardens, the vegetable gardens, and then the overall health of the people that are creating them. So as they're thinking about food security and what can I grow to keep healthy towards the future. So at the layman level, it's not just people that are working towards public health and working for climate change education, but even people that are growing their own food are interested in this.
Excellent. I'm going to combine a few questions here. One person asked if people are more sensitive to heat as Earth warms. I think we could also kind of look at what is our pre-adaptation to global warming. But I want to add to that question, because we discussed it a little bit prior to this when we were preparing for this webinar. People wanted to know, well, why not warn about lower heat levels? Obviously, there were increased risks. Katie, you showed in your data that there was increased risks at even lower temperatures. So what makes 95 such a relevant threshold? And can you say more really about the advisories and their efficacy more generally and warning fatigue? This person's wanting to know about you know, the social, the psychological aspect of hearing about heat impacts.
Yeah, so a lot of thoughts there. I think as public health and emergency preparedness continue to work together to address climate hazards, I think there's ongoing discussion of roles and responsibilities and what qualifies as an emergency that may mobilize large resources, financial and personal, and then the role of public health maybe to fill in the gap. And I think that those conversations continue to occur nationally, sort of when is it an emergency and what level of resources are necessary, but then what about everything in between? And we know that at-risk populations and perhaps the more vulnerable populations may need to take action sooner or hear the message sooner. So I think we continue to explore sort of the role of public health here in New Hampshire at the state and local level, sort of separate from the role of emergency responders. I think the second point is around, and this ties into the work that Janine really highlighted, you know, I think a huge part of this work is helping individuals or communities or organizations identify as potentially at risk. And so whether you're an older adult or a particular community, do you recognize that there are hazards that could impact you? And are you ready to take action in the event that those occur? And I think helping both individuals and organizations sort of create tools that help us then shift that perception will go a long way towards maybe acting more preventatively rather than in a reactionary stage.
Thank you. Janine, were the people who were predetermined to be vulnerable kind of validated as vulnerable? Or, and I guess we can open that question to all of you, but let's start with Janine.
That's a very loaded question. There were some people that, well, we are tough, we are Yankees, and no matter what happens, we're going to live through it, we're going to survive. Then there were those who take a step back and they have a wall up at the beginning, and some of the first responders actually did this at the beginning, which I thought was strange because first responders love to tell stories of the rescues. But at the beginning, in one of the sessions that I'm thinking of, they did not want to see themselves as being vulnerable themselves. Yet once they started telling their stories, realizing that people put them in harm's way by not preparing for this emergency that they had heard about several days ago, so that the first responders then had to go in and try to rescue them, and they were in harm's way. Some of them would get injured on occasion, unfortunately, and there's a higher risk for chainsaw injuries when people jump in to try to start cutting trees down and they're not watching what they're doing, or they're so revved up on adrenaline that they're not paying attention. And it's not necessarily the first responders that are doing that, but then the first responders have to go in and assist. So even first responders were identifying as being vulnerable once they started to think about it. They really needed to just stop and think about it. So I would say, yes, they did identify.
Katie, would you like to respond, or do you have anything to add?
I think just the point that I made earlier around really that risk perception is a key part of this, and whether individuals, communities, organizations sort of can recognize when they would be at risk and then take the steps necessary to sort of plan ahead and take that preventive measure so we can be sort of moving away from the reactionary framework.
Thanks. So do you ever get approached? Do any of you work with the school system? Someone was wondering, Lorena was wondering if there are plans to introduce emergency preparedness into the curriculum in public schools or in higher education so that future generations can prepare and respond.
This is Matt. I can kind of try to address that from two different directions. We do get approached by schools to do presentations, but it's often high schools or, you know, for staff development, things of that sort. But there's kind of, I think, a misperception, and maybe Janine can talk to this too, in behavioral science, that if you train children, they will train others above them through parents, families, and that hasn't really been proven true in the research literature. So I think there's a good reason and a need to do basic awareness training with kids, you know, some classroom activities, some fact sheets, some basic videos or other things that can kind of raise their awareness a little bit. But I think it's really the adult population we need to focus on.
I can remember the first time I learned about heat exhaustion was taking a first aid class, but kids really are exposed to a lot of outdoor activities in the heat in ways that many adults aren't, with the exception of outdoor workers and you know, important subsets of people. So I think that basic education is important. Just a reflection there.
Yeah, I think you're right that organizations like the Girl Scouts, Boy Scouts do great jobs. 4-H, excellent jobs around doing basic first aid and taking care of yourself, making plans for an overnight trip, and those are the organizations we look to kind of do that training.
Sabrina was commenting that there was no support for rain gardens and wondered what was underlying that social phenomenon. I think that's for
you. Say no support? No, it's not true. There's an effort through DES that's worked specifically with the Seacoast, and I can't remember the name of it, but they've had a lot of outreach to communities. They've engaged, they've brought rain barrels, they've done trainings, they've worked with Master Gardeners programs. So I feel like, at least for the Seacoast, it's been a big focus on it, and they have some of the biggest challenges with lack of groundwater. So I think it is out there. You just might have to search a little further.
And if I can address that too a little bit, Ned, the graph that I showed you with the 6 interventions on it, and you saw no support on that particular graph, that was because of the sessions that we held, our stakeholder sessions. Nobody in this region was feeling that we needed to focus on rain gardens and infrastructure right now. They wanted us to focus on human health and education component. So that's why that graph, yeah, just keep going back. that graph showed that there was a lack of support at this time for rain gardens in the Monadnock region. There's also, I had a really hard time trying to find literature to say that yes, rain gardens, we've proven that rain gardens really help. But I also attended a workshop that Matt was talking about with Department of Environmental Services here in New Hampshire, and trying to teach master gardeners how to incorporate rain gardens. And that was actually the focus of the talk that I did with the teachers a couple of weeks ago, is this is how you can help in your own way to mitigate some of the effects of climate change in the Monadnock region if you're a gardener. And so there is some science saying, you know, you take the stormwater runoff from your roof or from the street with all the salt and everything, and you capture it in this low depression on your property so that it drains very slowly and it cleanses itself. You're then preventing all of that polluted water from going into a groundwater system. And that's proven fact. And we also know that people in the Monadnock region, a lot of us have groundwater wells. So those of us with groundwater wells want to make sure we're not drinking polluted water. And so we are really trying to start educating people on that, but the data is not out there yet. And in this area, we just felt with the over 65 population that we really wanted to focus on education, outreach, and training. So that's perhaps where that question came from.
Excellent. Has any of this research or related research been incorporated into policy either by health insurance companies or the American Medical Association or other institutional partners?
This is Matt. There's no doubt that insurance companies are looking at the long-term trends in climate. I have a friend who works with reinsurance, which is the insurance companies that support the smaller insurance companies. And his job day by day is to look at how climate change is going to affect their charges and, I don't know what to call it, expenses in the future, the payouts that they do. So they're looking at it. And the only example I know of them really pushing policy is, I think it was in Michigan. One of the major insurance companies sued the state government a few years ago to force them to follow their own climate adaptation plan and mitigation plan, because they basically said, well, we can't do it because we don't have the money. And the insurance company said, listen, you went and discovered all these problems and said it should be fixed, and now you're not doing it, and it's going to cost us more money. So that was an interesting policy piece. It got settled basically out of court with, you know, actions they're going to take, but insurance companies are very interested in how policy is going to move forward, and they're one of the few private industries that are pushing it, as far as I can tell from a lobbying perspective.
This is Katie. The only other thing I would add is, thinking about the healthcare sector, I think I've seen evidence that, thinking about where they build their structures, making sure they have sort of long-term plans with sea level rise, but also at sort of a patient-provider level, if folks are on certain medications, recognizing the risk they may be facing during extreme heat events or other weather events. So I think there's both sort of the system-wide adaptations or long-term planning, and then sort of that individual level behavior and recognition of risks and working one-on-one with providers and patients. I don't know of policies, sort of jumping from the healthcare sector to maybe energy sector. One example is thinking about sort of the relationship between extreme weather and weatherization. And so in New Hampshire, for example, one project we're exploring is we have all kinds of programs to support heating during the winter, but now recognizing that heat is in fact a risk during the summer. Could some of those same benefits maybe be used to help people stay cool in the warmer months? So there are certainly some cross-sector policy initiatives, I think, happening as a result of a lot of this work.
And no doubt it's researchers such as yourselves who are really improving ultimately the appropriate application of climate information into setting insurance rates ultimately and things like that. So thank you for your work. Are there plans to include preparedness training to new public health hires across health departments so that the outcomes of this research can be applied more broadly?
Well, we're doing workforce capacity development through this program. So periodically, when people ask us in environmental health or other agencies across the state, we'll go out and do training around climate and health. We haven't specifically switched yet to working on emergency preparedness. One of the reasons is because the Homeland Security Office already does something called ready.gov or ready.New Hampshire. So if you search on the web for Ready New Hampshire, you'll come up with lots of resources, curriculums, and classes that are available to people. And I think within our own agency here in the Department of Health, if you're part of an organization that's working specifically on emergency response, whether it's radiological health or otherwise, you get that training when you come in, but no one's made a decision yet to train all the incoming staff.
Thank you. Can you give an idea of the percent of older adults in the Monadnock region currently? Nora mentioned that you had a statistic about 20-40 percentage, but she was curious about what the percentage is today.
Matt, do you have that
Something
figure?
she could probably look up.
Yeah, I know that by 2040, it's expected to be 26%, and at the beginning of this, around 2005 or so, it was listed as about 15%. So somewhere between 15 and 25 right now. But
that's a good
concern, it's as honest as I can be at the moment. But the concern with all of the health professionals in the area, the hospitals, et cetera, is that concern for housing for older people and services for older people, and then just medical for older people.
Thank you. What are the health risks associated with living in urban areas, like urban heat island effects? Or how about flooding or sea level rise? Jayshree is wondering broadly about urban health risks.
Yeah, there's a great public health history of, bad planning around heat events. Chicago in, I think it was 1992, is it? 95. And then Philadelphia had another heat event there, which had a very, very high mortality. And we've learned a lot from those and tried to adapt and update in the urban areas. And it's become more of a kind of all hands on deck planning approach. So that's the heat side. And on the, in terms of flooding, we see Miami area and some areas in the Carolinas that flood at high tide now and king tides, and they're doing some of the early preparations for how you manage those. But some areas, you can actually build dikes and build roads up and survive that. In other areas like Florida, which sits on top of a large ancient reef, I'm trying to remember the name of the actual stone that's underneath there. But basically, when the water comes up against it, it's so porous it goes in and rises up. So there's no way to hold it back like you can in some places that are built on granite. And maybe I'm thinking of, in Scandinavia, the Dutch who are able to kind of hold water back. So some places it work, some places it won't. And there'll be some retreating of populations in commercial areas if the sea level rise continues as it is. So that was two things. Was there a third thing from an urban perspective?
No. Those were the two that were mentioned, and I think you covered them. Thank you. So Amy, who has left the webinar right now, but we'll get this answer to her, said that many of the interventions discussed focused on individual and community resilience. However, some barriers to building resilience are more infrastructural. For example, people who need oxygen and refrigerated insulin, they'll need generators, or those with limited mobility need wheelchair access to emergency shelters. So how do we make sure communities have those appropriate resources?
I would look to our community action programs who already do work in that area to work with the individuals. And then for community resilience, that's some of what we're kind of exploring now. How do you build neighborhood level and town level resilience to these climate changes?
And to play off of what Matt said and to add to her question, A secondary question is, how do you know where these people are that need the refrigerator for the insulin, that need the wheelchair to get out of the house? And that was a topic that came up in conversation over and over and over again, with especially with the first responder groups that we had sessions with, is how do we find out where these people are? And in our particular region, the fire chief is the knower of everything, or the person who runs the local general store. And we heard stories from a person that was in Vermont during the hurricane a few years ago, Irene, that wiped out parts of Vermont. And if it wasn't for people going to that woman and saying, you know, who in the area needs help, first responders would not have known where to go to look. So part of that is local knowledge, and it's, again, the community helping the community, that community engagement component. But it's very, very difficult to figure out how do we deal with the infrastructure issues.
Those are excellent answers. I really appreciate the fire chief, general store owner, but the community action plans, I mean, there are processes for also surfacing some of this knowledge. So those are great answers, thanks. Do any of you know of examples where building codes have been revised to incorporate climate and health findings so that buildings themselves are more more resilient living environments?
This is Katie. I would just say that, you know, that work tends to move well beyond sort of our scope of work, but certainly, you know, green building initiatives are happening nationally, and I do recall some stories around hospitals sort of using funds to maybe put a parking deck below the building on the first floor as they plan to adapt to climate change. And so I don't have specific examples here in New Hampshire, and our program certainly isn't focused on that. Sort of, you know, the reality of our grant fund that we need to focus sort of explicitly on those acute health outcomes. So our interventions tend to not always
that topic came up,
big scope.
The topic came up, Katie, also when we were doing our stakeholder sessions with Keene Energy and Climate Committee. The city of Keene also has their own climate health and adaptation plan, and we went to that committee to ask the same questions we asked everybody else. And they're focusing on solar, and they're also focusing on the discussion right now is to try to build a fire station that can serve as a shelter that is run by solar, so that when there are flooding issues in certain parts of Keene, they have a way to provide refrigeration and power to people to charge their cell phones, to take care of their insulin, etc. And I don't know, the last time I talked with them was about a year ago. I don't know what stage they're in, but they are looking at that as a way to try to help, at least in the Keene area.
I think it would be helpful for the participants on this call to think about physical infrastructure versus human infrastructure. There's a lot of organizations working on physical roads, culverts, you know, armoring the coast and changing the way water flows and such, and they're doing a great job. We're taking a different approach. We're really saying of the human infrastructure, of the people, of the professionals, how are we kind of working with them to make them more resilient as individuals or more resilient as a community. So it's less visual and it's harder to achieve in many ways.
Excellent. Those are some excellent answers. Last question, and this is super easy. Katie, I think you probably know Nora Travis. She asked if there's a paper or report that you can check out. I think we had to skim past that, and we can email her a link. So I would encourage all of you, if you have references that you want to send out, we can send out a thank you email to everyone who participated and include links or publications that you want to share or anything like that. So with that, I want to thank all three of you for today's session, and it was very informative. I really appreciate the boots on the ground, as well as the the academic research bridging across all of those levels of understanding. So thank you for your work. And we'll conclude the webinar now, unless any of you has anything you want to add.
No, thank you, Ned. You did a great job facilitating.
Thank you.
You're very welcome. Bye-bye.
Bye.
Gary, are you still there?
Yes, I am.
All right. So I'm going to end the webinar. Let's see if we stay on the phone.